Good morning, afternoon, evening, and welcome to Concerned Citizens Presents, a new offering on Village TV. Concerned Citizens of Laguna Woods is an organization committed to peace, social justice, economic equality, and a clean environment. For the duration of the lockdown, instead of its usual 2 meetings a month, Concerned Citizens will broadcast 2 programs a month on this channel. Our programs will feature films, lectures, and debates on topics related to our mission. We hope you enjoy today's program.
Welcome to Concerned Citizens Presents. Concerned Citizens is a nonpartisan organization located in the Southern California retirement community of Laguna Woods. Our mission is to promote world peace, social justice, responsible government, and a clean environment. Every month, we invite an expert to speak on a pressing issue. But today is April 24th, 2020, and America is in the midst of the coronavirus pandemic. All Californians are practicing social distancing, so concerned citizens cannot hold an actual meeting. Instead, we are video recording our programming so you can see it at your convenience. For today's program, I am conducting an interview with Dr. Paul Song. Dr. Song is on the board of directors of Physicians for a National Healthcare Program. He is a board-certified radiation oncologist, a stakeholder in immunotherapy research, and a political activist. It is in his activist role that Concerned Citizens has invited Dr. Song to speak. Welcome, Dr. Song.
Thank you so much for having me remotely.
So, please, to begin, what is Physicians for a National Healthcare Program, and why or how did you become involved with it?
Well, it's an organization that's been around now for over 20 years. It was initially founded by 2 amazing primary care physicians, Steffi Woolhandler and David Himmelstein, out of Boston, and they started an organization of physicians that was really designed to bring like-minded doctors across the country who felt that the current healthcare system was not sufficient, and the best system that was available was a Medicare-for-all system. And it was really born out of the fact that there was no other organization or place for us to go to. The American Medical Association has never really embraced or adopted anything other than our private insurance-run programs. So it was really born out of necessity, and has since grown into a very large group of not only physicians, but healthcare providers in general.
And when was it started?
It was started back in I think I'll have to check, but at least sometime in the late 80s, early 90s.
Okay, so more than 2 decades now.
Yes.
Right. Okay, well, let's talk a little bit about the response of our current healthcare system to COVID-19. Can a person who has no insurance, not even Medicaid, which is our program for the least advantaged, can a person with no insurance get treatment for COVID-19? And if so, who pays?
So that is a good question right now. So prior to the most recent relief efforts that have been passed by Congress, that was the challenge for people that were uninsured who were walking around with symptoms that were highly suggestive of a COVID infection. Many of them did not have the means to go to the doctor or to an emergency room. So as a result, probably were in our community spreading the disease for much longer periods of time. And remember, there was also a lack of testing. Since then, you've had several initiatives. One is now there is legislation to reimburse hospitals to take care of uncompensated care. So people who are uninsured who do show up in their emergency rooms and ultimately get admitted to the hospital, there is now some congressional funding to reimburse hospitals for that. But still, I think the challenge for people who don't have insurance is to find an initial facility that will see them. The other part is that with Medicaid, as you mentioned, which is the healthcare program for really those that are have less than 138% of the poverty line in the United States, they here in California, the challenge is very few doctors and hospitals accept Medicaid. So even if you have that coverage, trying to find a doctor who will actually see you, spend time with you to diagnose you is problematic. But I would say this: if somebody in your group knows of somebody who is uninsured, there are more and more services available to them right now in this time of COVID. Now, once the virus hopefully subsides and we regain some normalcy, sadly, a lot of those people will go back to being uninsured and unable to get healthcare. But right now, is it specific to COVID-19 and the recognition that it doesn't matter if you're insured or not, you will be a threat to your community if you're not properly treated and diagnosed. The government has taken steps to try to not only pay for testing, but to also cover treatment of uninsured.
Okay, so in a sense, what you're saying is there's a separate program that's kind of set up for the Medicaid population. Here's a slightly different question, but also about budgeting. So what about Medicare? Is Medicare an infinite pot such that we don't need any supplemental? We can count on us who are Medicare eligible that you'll always be there for us.
Well, I mean, that is the promise. And I think, but the reality is that Medicare does need to come up with additional funding sources in the next several years, and certainly in the next decade, as more and more baby boomers become Medicare eligible. But one of the things that I think is unfortunate is the way Medicare has been couched. First and foremost, for those of you who are on Medicare, you all paid into it. It wasn't something that is just given to you. That certainly during the course of your working years, you were having a percentage of your paycheck deducted to go towards Medicare, that when you turn 65, you would be able to enjoy the benefits. So sometimes when I hear people say that it's an entitlement, I find it to be somewhat offensive, because that assumes that you didn't pay for it. But in reality, every senior that is now enjoying their Medicare paid into it at some point. Secondly, though, it is, as healthcare costs are becoming more expensive, the amount of money in that pool is becoming somewhat strained more and more. So I do think that there are going to need to be several choices that you'll hear about once we emerge from this current situation. Prior to this COVID-19 situation, you started to hear grumblings that the Republicans were going to balance the budget. Remember, they further ballooned the deficit with the tax cuts by doing that, by cutting benefits for Medicare and Social Security and other things, which I think is completely offensive and immoral to do so. But independent of that, that has clearly been tabled. I think what's going to happen, though, is you will see in the next 10 years something that needs to be done to further strengthen Medicare in terms of either raising taxes or cutting benefits. And I would imagine that either of them are not palatable, but I do think you are going to need to come up with more money. And if you don't do so, that in the next 10 years or so, Medicare does stand the potential of running out of money.
Okay, well, that's a little bit scary, but perhaps not a surprise. Let me ask a slightly different question. There is a lot of variation in the death rate per 100,000 from COVID-19. For instance, the US seems to rank relatively high among countries in the world, but Switzerland or Spain have a higher death rate than the US. Similarly, there's a lot of variation among states. So California ranks relatively low, but viewers might be surprised to know that Texas ranks lower yet. So on the one hand, one is perhaps tempted to make an association between healthcare delivery, both nationally and internationally, and these rates of variation in death rates. So how how do you look at that? And is there anything we can learn from these variations, both nationally and internationally, and the number of people that are dying of COVID-19?
It's a great question. So there are a couple things to really think about. One is that we're still learning so much about this disease. And while the incidence and death rates have been lower in Texas and in other southern states, we're not out of the woods yet. And I think you will start to see some spike in, unfortunately, infections and deaths in the coming months, because particularly in Georgia, where you're seeing them relaxing the social distancing. With regard to how other countries have had Italy, say, compared to, say, Korea, or you have Spain, as you mentioned, or Switzerland, there are so many other factors that come into place. One is how aggressive is the testing, the surveillance of people, the quarantining. What you saw in Italy was very dramatically different than what you saw in Korea, where they really tackled the testing and the contact tracing extremely aggressively in the beginning in Korea, but they didn't do it in Italy. And as a result, you saw this massive explosion of infections. I do think with regard to the United States, what we can learn is if you look at the death rates, in the beginning, we were told this was a disease that was primarily affecting people over the age of 65 or people who had other underlying health conditions. What we're now seeing is in states like Louisiana, the average death age is substantially lower, people in their 40s and even as low as in their 30s. And the difference is that you have to look at beyond just age, right? There are, I'm sure, like yourself and others that are very quite healthy, and you can put a lot of people 20 years younger to shame in terms of if you look at their smoking history, or they don't exercise, or they're eating too many fatty foods. So there's a lot of complex issues that underlie why people are vulnerable. So if you look at the death rate, it's disproportionately higher in the African-American community compared to others. And what we are seeing is because of the actually their health access to healthcare is not as good. The access to healthy vegetables, a lot of them are in food deserts. A lot of them live in communities where there's a lot more pollution. There are a lot of underlying factors than just age that make you more susceptible. And then in Louisiana, if you look, their health coverage has not been great. They were very late to expand Medicaid. So there are a lot of people there with untreated diabetes, untreated hypertension, obesity. And I think if you look at that, that all plays into sort of the inequality in our healthcare system that you mentioned. Finally, I'm just going to say this about California compared to New York, right? So we are the most populous state in the country. But one of the things is, because of our lack of public transportation, a lot of people were spending a lot more time in their car by themselves, stuck in traffic, than they were with 50 other people in a car in a subway. And we don't tend to live on top of each other, right? It's much more of a sprawl in Los Angeles and in the cities than you have in New York City, where you just have high density, high populations. So I think the reason that you're seeing such the explosion of cases in New York compared to even Los Angeles is there are two factors. One, you have a very international community. A lot of people travel to Asia and Europe over the holidays, came back unknowingly, were infected, and really started to spread the disease. But it's much easier to spread the disease in a subway car than it is driving on the 405 in traffic, right? And so those are all the factors that really come into place. And also, I think the social distancing was a big part of why we've been able to keep our infection and death rate down low compared to other states. But also, it's just geographically our sprawl that has also allowed us to, in some respects, social distance. When you're stuck in a car for an hour every day in traffic, you are, in some respects, social distancing. So there are a lot of factors, but I do think what's going to be important is you'll see in the next month, certain states emerge from this quickly, or quicker, like a California, maybe a Washington, and other states who are starting to emerge too quickly now, go back, take a step back, sadly. So The concern that a lot of public health experts have and government officials have is that we will see the second wave of infections in those states that you mentioned, like Texas and Georgia, that have not had much so far.
Well, thank you. That's kind of the answer I expected. There are a very large number of causal factors here, and it's also early in the game. Still, I would suspect, we shall see, that when the data do play out, a year or two from now, and we can begin to take different factors into account, I'm hopeful that it won't just be perverse incentives like being alone in your car that are good, but that actually maybe the healthcare delivery system does matter. And anyway, so let's talk a little bit about Physicians for a National Healthcare Program, which is what Concerned Citizens really was motivated to have you speak about. What is single payer health insurance, and why do you and your organization support it?
So one thing is, so I'm a radiation oncologist, as you mentioned. I started practicing back in 1995, so it was a long time ago. I went in there bushy-eyed and very optimistic, but after a couple years in practice, I started to see several of my own patients who had cancer, who had done the right thing. Many of them had worked their whole lives, had private insurance, good lives, suddenly become financially bankrupt because of the toll that their illness was having. Particularly back in the day, there was no lifetime cap, and there was a lifetime cap on what you could exhaust. So if you were, say, a woman that had been fighting breast cancer for 6, 7, 8 years, you've pretty much ran up against your maximum cap. I also saw sort of the insensitive nature of the insurance industry just denying care when it was really appropriate. And it became very, very hard for me to just see that happening to patients. So I began to research what is wrong with our healthcare system, what is the inefficiencies, why are people's premiums continuing to rise, drug costs, things of that nature. And really from that did my own sort of journey as if I was trying to find the best way to treat a specific type of cancer, devoured lots of policy papers, research, and really came across what I believed was the best plan, which is a single payer Medicare-for-all plan. So let me explain a little bit about simply what that is. It is not a government takeover of medicine. It is not socialized medicine. Let me explain to your colleagues. So socialized medicine is when the government owns and operates every aspect of the healthcare system. It owns the hospitals, it owns the pharmacies, the radiology equipment, it employs all the doctors, nurses, pharmacists, radiology techs, laboratory techs. Every aspect of the healthcare system is owned and operated by the government. That is a system that Great Britain has. That's a national health service. That's a system like countries like Denmark have. But it is not, and ironically, we have that system here in the United States, which is called the VA system, which is ironic that you have these people fighting for our freedom, and yet they're very happy under a socialized medicine system. So that is socialized medicine, and that's not what myself or Physicians for a National Health Program are interested in nor advocating for. What a single payer system is this? When you think of how fragmented our healthcare system is, just take, for example, let's say, when you were in the workforce and you were getting your coverage through your employer. Let's say one year it was United Healthcare, and now all of a sudden your employer decided it was too expensive and we're going to go with Aetna the next year. And then all of a sudden now you turn 65 and you retire, and then you take Medicare. For a hospital or a doctor, every time you come into their office, they've got to figure out, wait a minute, you're no longer United Healthcare. Am I in your network? Can I see you? If so, what's your copay? What's your deductible? What is, if I need to refer you to a hospital or admit you to the hospital, which hospital does your insurance have a contract with? I can't send you to Hoag. I have to send you to a hospital all the way in Long Beach because the insurance won't cover it. So all of this inefficiency is baked into the system. Meanwhile, the private insurance industry is taking 15 to 20% of every healthcare dollar away from actual patient care to pay for marketing and sales, for administrative costs. and at the same time, profits. And for a doctor's office, they're spending all this time fighting with insurance companies to figure out all of the things and get paid for the procedures that they'd like to do for you. And it's taking away actual time and money from actually seeing patients. So what a single payer plan is doing is not eliminating your private choices or options. If anything, it's allowing you to go to any doctor, any hospital that you want. But rather than having to constantly show your insurance card, it's the same. And if you were to get fired or you quit your job or you retired, the doctor wouldn't have to navigate what your plan was, and it would be much simpler. And the idea is by doing that and making the system simpler, you save a tremendous amount of money in terms of administrative costs and simplify the system. And that money goes to strengthen Medicare for seniors. So right now, you have an 80% coverage on outpatient costs, and then you either have to come up with a supplemental or bear the burden. The idea is by bringing everyone into the system, you would have 20-year-olds, 30-year-olds who maybe were more healthy, but now they're part of the system. So you have this huge infusion of cash coming into Medicare. So one of the things you talked about was, what is the potential that Medicare could become insolvent in 10 years? Well, now all of a sudden, instead of everybody paying premiums, everyone's paying into Medicare, you bring in this huge pot of money to now strengthen the resources. So you not only for seniors increase their security and knowing Medicare is going to be around, but you increase the benefits for which they have. There's no longer the 80-20. There's no longer the need for supplemental insurance or all of the things that are noted. And at the same time, for workers and employers, they end up having to pay far less for healthcare than they would to pay for private insurance for their employees right now. And one of the things people don't realize is two things about our current healthcare system. There's now been about 11 million people who have lost their health insurance in the last, since this coronavirus situation hit. As they lost their job, they lost their health care. And the second part is you recently have heard that the private insurance industry said next year they're going to have to raise premiums at least 40% to make up for all the costs of healthcare this year. So it's bad enough for corporations that have had this huge slowdown and are trying to struggle to keep their workers or having to lay people off. But now next year you tell them, we're going to have to increase your healthcare costs 40%. So there's a lot of myths. During the Democratic debate, you heard a lot of members say, well, when Senator Sanders proposed Medicare-for-all, you're going to kick all these people off their employer-sponsored health plan. Well, we just lost 10 million off their employer-sponsored health plan. And the good thing about a Medicare-for-all plan right now, if we had one, for all those people that lost their job, the one thing they wouldn't have to worry about is they still would have health care.
Right, right. So oftentimes one does wonder over and above the insurance industry itself, where the motive comes from not to make the switch. So let me ask you a question in that regard. I'm curious what the effect of single payer would be on physicians' incomes. So currently, as you just said, Medicare is an example of single payer. Let's take an identical medical procedure like a colonoscopy, for example, or a hernia repair. On average, currently, which plan reimburses physicians more generously, Medicare or the average private insurance plan?
It's a great question. So it really also depends on what part of the state, the country you practice in. So prior to moving to California, I was in practice in around Washington, D.C. and Northern Virginia. And I accepted all patients. We had Medicare, Medicaid, and private insurance. And at the time, private insurance paid dramatically more than Medicare did for procedures. Usually somewhere on the average of 1.2 to 1.5 times what the private Medicare would pay. But there are a couple issues with that. When I moved to California, soon a lot of the private insurance plans, and particularly the HMOs, were paying the same as Medicare, if not, and now some of them are paying less than Medicare. What they're using is they're becoming so powerful, they're basically going to doctors and saying, if you don't accept this rate, we're not going to include you, and we're going to go find other doctors who will take a cut rate because it's become so competitive. So I would say to a lot of doctors out there, particularly in California, look at the number of contracts you have right now that are paying no better than Medicare, or in some instances less than Medicare. And then look at the administrative costs that you have to hire people to fight with insurance companies to get paid rightfully for the procedures, or for pre-authorizations or denials. So the average doctor's office back in 2015 was spending 20 hours a week on the phone with an insurance company getting pre-authorization for their patients. That was the average doctor. Now, on top of that, you take their office, they were spending at least $83,000 per doctor to hire somebody to handle billing and to fight with insurance companies. And that has only gotten more expensive over the last several years. So what I would tell people is, if physicians, if you have a single payer plan, you're going to have 20 hours more a week that you don't have to get pre-authorization, that you could actually see more patients during that time. You will actually have less administrative costs because it'll be much more simplified, and you're not going to have to fight. Physicians, we never have to fight with Medicare to get approval for patients or to do procedures or do any of those things. It's much more simple for us to deal with Medicare. So while we might make slightly less per patient or per procedure, our quality of life will be dramatically better, and our overall office costs will be less as well.
Well, that brings to mind then a kind of a related question. So let's just say on average Medicare pays less, yet the Medicare patient, as opposed to the Medicaid patient, as far, at least in my experience, it is not denied. You know, Medicaid, they must pay way less, and so very few physicians want it. But in general, Medicaid, doctors will accept that. So then my question is, why is it, I can suspect an answer, but I'll ask you, why is it then that Medicaid actually reimburses less, but let's say 90% of professionals are willing to accept that?
Well, I think
send us packing like they do the Medicare.
Yeah, because again, the reimbursement for Medicare is not bad, and I think that you have this dichotomy within the medical community. So you have people who say were practicing before, they were practicing in the, let's say people who were slightly a generation above me that started practice in the early 80s. Back then, the private insurance industry was reimbursing doctors extremely well. They remembered the good old days when they were making a lot of money. At the same time, they also realized Medicare was quite easy to treat, and you inevitably had this mission to take care of everyone. What's happened now is you're seeing a whole new wave of doctors come in who never had those great days of being paid big bonuses from the private insurance industry in terms of reimbursements and things of that nature. They've only operated in the system right now where it's been Medicare or Medicaid. And they are very willing. And also they're in medicine right now for all the right reasons. For people now to become a doctor and end up with $200,000+ in medical debt, medical school debt, they've got to do it for the right reasons. So it's a little bit different philosophy. So you're seeing this generational divide. You're seeing doctors who are probably 45 and under who are overwhelmingly embracing a Medicare-for-all plan. And the doctors that are over 45, the majority of those oppose it because they remember the good old days when they were getting paid a lot more.
So tell us, what do you think about physicians in terms of their support? There's a generational divide. Are there more older doctors than younger doctors? How does this play out in terms of doctors generally favoring or opposing Medicare for all?
So ironically, at the American Medical Association, the leadership there is all pretty much opposed to Medicare for all. Mm-hmm. But they are also doctors that have been in practice for 30+ years. They're the generation that really wants government, doesn't want a government-run healthcare plan. But they're becoming more and more the minority. The last poll among physicians was that a majority of physicians overwhelmingly supported Medicare for all because physician burnout is now at an all-time high. More and more doctors are being so discouraged because they're spending more time on a computer putting in all these charting on behalf of things you have to do for an insurance company rather than taking care of patients. This isn't why they went into medicine. It's really, and the business of it has become so unsavory that it's taken away a lot of their joy of actually taking care of patients. So I do think that you're seeing a large percentage of patients, even that tend to be now older, who are saying, this isn't fun anymore. I want to go to a more simple, civil way, even if it's being reimbursed less. And so the last polls have shown over 55% support for Medicare-for-all.
That's great news. That's wonderful news. I would wonder also if one of the attractions also is more autonomy. I mean, this notion that the expert knows what needs to be done, and the bean counter is denying that option. It must be, it can happen once in a while, but if that happens enough, I think for a professional person, that's tremendously frustrating.
It really is. It certainly was one of the most frustrating things for me in my practice, that you had somebody who had never taken care of a cancer patient, let alone a patient, telling me what I could and couldn't do for my patient. And I always feel like I've been doing the right thing based on what the medical data and research shows, rather than doing anything to maximize any profits. Secondly, I think the other part is that you now have doctors, because the insurance companies become so powerful, a lot of doctors could no longer hang their single shingle by themselves and be in practice by themselves. And instead have had to join big group practices or have their practices bought by big hospital chains that are equally predatory. So I do think that if you were able to go to the system, you could have more mom and pop type of doctor practices reopen, and doctors could have their autonomy restored at that level as well.
Right. Well, then let's move a little bit more into the political realm. Currently, the option voters have is Joe Biden or Donald Trump. So if one is leaning a bit more towards universal health care, one would support Biden. However, among other things, he does not support single payer. He wants to expand Obamacare. And he has talked about adding a public option to the private options already out there, rather than making it one public option for everyone. What is your and your organization's response to his positions?
Well, we think there's real dramatic differences that we have with his policies, and we don't agree with his conclusion. So let's take the public option for one. There is having a public option certainly would be better than no public option, in the sense that you would actually have something that could compete with the private insurance industry to keep them honest. The problem with this is that the insurance industry is smart. So what they would do is find a way to make sure that the sickest, most, the patients with the greatest number of health conditions had to enroll in the public option. And they would keep the healthiest patients in their plans. They could do this with certain types of, deep data mining to figure out lifestyles, things of that nature. So that's one. So the government would then incur the responsibility of taking care of our most unhealthy patients. The second part is it doesn't solve the issue of reducing our costs. So if you have a public option, you're just introducing one additional layer into our already complex system. And just as I mentioned, you have United Healthcare, Aetna, Kaiser, Blue Cross Blue Shield, all of these plans, and it's hard for a doctor's office to keep track of that and hospitals to keep track of that. Adding a public option is just adding one more thing that keeps everything further confused. And it doesn't allow for the cost savings. So there are three major reasons that a single payer system works. One is that the simplification of the administrative, it's just one payer, so that you have a coverage that can cover everyone without having to figure out who or what your plan is once you move around. Second part is that when United Healthcare or Kaiser uses all of its market cap and share to negotiate drug price discounts, they consider that good free market or business sense. But if Medicare is trying to negotiate drug prices, it's considered government interference. Well, you pool all 330 million people in the United States together, guess what? Our drug prices will be cheaper than they are in Canada and Denmark and elsewhere, like other countries have done. And then the third part is the overall efficiency of our system. So a public option doesn't solve any of that. So that's the biggest thing that we would say to Vice President Biden on his proposal. Having said that, I think he is much more willing to support and build upon the Affordable Care Act, where you have President Trump trying to dismantle the Affordable Care Act. So as far as healthcare, if you have to choose between the two, I think that Vice President Biden is much more favorable to patients than what we've seen so far.
Right. So actually, I mean, as I recall, even when the Affordable Care Act was being touted, there were claims that it was going to bring us a substantial reduction in healthcare costs, but that actually didn't happen at all. In fact, there might have been some minor savings, but overall things ballooned and continue to balloon. So it sounds to me like one of the things, one of the criticisms that you're making, which is really important, is that in order to get a handle on this, we need to put everybody in the same pool and cut the profit motive. And
absolutely,
it's very difficult for a politician to do that.
Well, here's the truth of it. In the run-up to the Affordable Care Act, remember, we had a supermajority and you had a Democratic House, Senate, and you had a Democratic president. But you had 3,300 registered healthcare lobbyists for the 535 members of Congress. They were spending more than $1.2 million a day. More was spent lobbying Congress for the Affordable Care Act than was spent on the Bush-Kerry election. And that's why the final Affordable Care Act, while it did do a lot of positive things, had no insurance rate regulation or drug pricing control. And if you ask most people what are the two areas that they're most upset about, is the runaway cost of prescription drugs, and secondly, how their premiums keep going up unreasonably high year after year after year. And that is deliberate because too many members of Congress are listening to the pharmaceutical industry and the insurance industry rather than their own constituents.
So that leads right into my next question, which is, given the pandemic, which really brought healthcare to the fore in ways that actually previously it wasn't. The Democrats were pushing it, but it wasn't really on most people's minds. And now it's got to be on everyone's mind. So do you think that support for single payer might grow as a result of the pandemic?
Yes, as a matter of fact, there was a recent poll that showed single payer support for single payer nationwide is now at an all-time high. But whether or not our politicians will listen is a secondary question. Again, it gets back to the whole idea of all of these people, particularly people in unions who were adverse to single payer because it felt like that would take away their union, hard-fought union healthcare. Well, a lot of those people have lost their jobs now, and they don't have union healthcare. And a lot of those people, if they wanted to maintain their healthcare that they have to pay for COBRA. But you have to have a paycheck to pay for COBRA, right? The government, your former employer will cover part of it, but you still have to come up with a sizable amount each month to ensure your healthcare benefits. So the reality is really set in for a lot of people who maybe didn't fully embrace single payer because they were so secure that that they would continue to get their health coverage through their employer and they would have great private coverage. Now that they don't have it, and as I mentioned, of the 25 million people who've lost their jobs, they think now somewhere between 9 to 13 million people have lost their health insurance as well. It's a reality check that maybe a single payer plan would have been better for them in the long run.
Right. So actually those people are also, unfortunately, rather more likely to vote than the people sort of at the part of the issue. It's not the whole issue because obviously politicians do not necessarily respond to their constituents. But to the extent that the constituents have an impact, it's doubtless been the case that a high proportion of constituents have reasonably good health plans. They don't know what the doctors are suffering in terms of autonomy and overhead and so forth. So yes, so I can see how this might motivate the public, a larger proportion of voters, to be concerned. So that leads me to my last question, which I hope you're going to give us some advice. So obviously, many of our viewers and perhaps our viewers' friends have been moved, if they weren't already there, to support single payer. So could you please tell us very specifically how we might be able, whom we should contact, what we should do to try to promote this agenda, and maybe also a little bit about when?
So a couple things thanks for the question. First and foremost, I think with regard to your community at Laguna Woods, Medicare for all would actually make your health care better than what you have right now. It would not further weaken Medicare as you know it. Not only would it do away with the 20% that you're responsible for, but it would provide vision, dental, as well as hearing aids, and at the same time, long-term care. So I do think that if you look at, and those are things that my mom, she's 88, she's on Medicare. I think she worked hard her whole life, as all of you have. I think those are things that are deserved. So that's the first thing I would say, that would improve benefits, not just for everyone, but especially the senior community considerably. So a couple of things I would say is, one is to educate, to learn all about what a Medicare for all plan is. They can go to www.pnhp.org to really see real policy paper. They're not ideologic. These are real, based in fact, research proposals and research that have been published in peer-reviewed journals. So it's not some ideological
fact-based. Are you trying to
It's really fact-based, yes. So that I would say learn about it, and then start talking to their friends and family about it, and then really start to hold their elected officials accountable. Now, the good thing is I think Katie Porter is your Congresswoman, and she is very much in favor of single payer. She's been an amazing advocate for everyone. I'm so proud of all that she's been doing there. But you have other people in the districts and in the counties, particularly in the state legislature, who are not really trying to do the best for their constituents. So I think to try to get active by telling Katie Porter, I think it's important to get her reelected, but to tell her how you guys all have her back and that she needs to continue to be a leading voice on this. And then really start to put pressure on Senator Kamala Harris and also Senator Feinstein to really start to support this as well.
What is their record, Dr. Sondland?
Senator Feinstein has never been in favor of Medicare for all. Senator Harris, I think it's quite mixed. On one hand, she said she was when she first launched her presidential campaign, and then quickly morphed into she wasn't as certain about it. So I think that, again, if you have a community that wants to be active, to call their office, to send emails, they do pay attention to the flow. And if an overwhelming number of their constituency is really pushing them on something, they can't ignore it. So I think that's really important to do.
Great. Okay. Well, we'll try to get to work on that, and we'll also try to pay attention to when related legislation is being considered, because that's usually, the best time to try to advocate. So that concludes our interview, and Concerned Citizens thanks you for the time you've spent with us today. You've certainly given us much food for thought, and we wish you good luck as you struggle to keep America healthy.
Thank you so much, and thank you for having me.